Good morning, everyone. My name is Robert Hersey. Happy Wednesday to each of you. And on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Trauma Informed Care and Substance Use Treatment with Young Adults. This webinar is being made available through a collaboration of the Florida Department of Children and Families and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them to all panelists by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the Communicate menu. For computer audio, click the Communicate menu, then click the Audio Connection panel, click Disconnect, click on the Communicate menu and Audio Connection buttons again, then click Call in using the computer and follow the on-screen instructions. If you continue to experience poor audio through your computer, try using the I will call in option under the Communicate menu. The access code and event password will be posted in the chat panel. You must be connected to the audio of this presentation as well as view it on screen to receive a statement of completion. We are unable to verify your attendance if you are not connected to WebEx via your computer or mobile device. Therefore, audio-only attendees will not be eligible for a statement of completion or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and then click on Training Library as shown on the screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. A statement of credit and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at the end of the day on Monday, June 3rd, 2024. At the end of today's webinar, you will have 3 opportunities to complete the evaluation. A link I post in the chat, a follow-up email from WebEx, and an automatic web browser pop-up when I end the webinar. To complete the evaluation, you will first need to register or sign in to your account. Please ensure your name and email address match the name and email you used to register with today's webinar. Information you provide FATA as part of registering remains confidential. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. If you need assistance with account registration, login information, or accessing the evaluation, fill out a contact form on our website or email training@floridabha.org before June 3rd, 2024. Please note that WebEx monitors the arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Statements of credit will be posted within 30 business days after the evaluation closes in the professional development section of your FATA account. For licensed practitioners, CEUs will be posted to CE Broker within the same time frame. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, the Florida Alcohol and Drug Abuse Association, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today will be Ashley Shaunaberry. Ashley specializes in working with young people, particularly those experiencing early mental health symptoms or seeking therapeutic intervention for the first time. Ashley currently provides trauma-informed treatment at a Chicago hospital and, in her spare time, offers trainings to organizations on how to decrease compassion fatigue and normalize mental health treatment for healthcare colleagues. As a former team leader of a coordinated specialty care team for early psychosis, Ashley engaged in preventative work and crisis intervention using a strength-based approach to help youth, young adults, and their families create more sustainable, healthy, and adaptive patterns. A graduate of Michigan State University, Ashley's career has focused on community mental health and working with underserved populations, promoting rural mental health services, engaging youth in residential settings, and collaborating with families involved in court-mandated services. And now, Ashley, I will turn it over to you.
Thank you for that introduction, Robert. Happy to be here this morning. It looks like Florida is pretty warm today. Someone mentioned 95 degrees. Just for context, I'm logging in from Chicago, where I currently reside, and it's 50 degrees and sunny. So definitely a little bit different here, but it's not too bad. So we'll go with that. So we're going to go ahead and get started. Let me further introduce myself. So currently I work in outpatient behavioral health as a therapist at a safety net hospital in Chicago. What a safety net hospital is it's a hospital that's willing to provide services for individuals regardless of their ability to pay for services. So sometimes that means individuals who may be on state care, so Medicaid, Medicare. It could also be for individuals who don't have any insurance. One of the draws of working at my current position was that it offers different grants and programming to provide therapeutic services to individuals, regardless of their ability to pay. And there's specific programming that will cover the cost of individual therapy and or psychiatry for those experiencing intimate partner violence. So one of the things I really like about this approach to services is that it creates space for individuals to receive necessary services without focusing so heavily on what insurance they may be coming in with. So prior to my current role at the hospital, I've worked as a team leader and supervisor on a first episode psychosis team. So that was for youth and young adults who either had experienced a first episode of psychosis within the last 18 months, or it was determined that they might be at risk of experiencing an episode of psychosis. And that could be due to genetics, it could be due to specific symptoms they might be presenting with. And in that job, I learned a lot about ways to think outside of the box and be really creative in my approaches of working with young people, which further helped me grow personally and professionally. And I'll talk more about that as we go on today. But working with young people is something I'm truly passionate about, and it's something that showed up in many of my roles. So historically speaking, I've worked in residential facilities. I've worked in with individuals within the foster care system. I've worked with families that were either at risk of having their child removed from the home, or they had their child removed from the home, and they were trying to get their child back in the home. So In all of those different experiences, one of the things that stands true is that trauma shows up in many ways, shapes, and forms. And we'll get into how to look for that and what we can do about that. So let's dive in. The objectives for today is to define reasons to be trauma informed and reduce the risk of re-traumatization. So we hear this term trauma informed so much, and we really want to define what that looks like and also recognize the capacity to be preventative in not re-traumatizing individuals who have experienced trauma. Next, we're going to discuss trauma screening tools and treatment considerations specifically for young adults. And lastly, we're going to identify specific trauma-informed approaches to care at organizational and clinical practice levels. So the next part is where you all come in. What do you hope to learn today? Please answer this in the chat, and remember to respond to all panelists. But what is it that you're hoping to get out of today's presentation? Is it to further define what it is to be trauma-informed? Is it to feel more comfortable working with young adults? Was the pull to get some CEU credits, which I totally understand because that's definitely important and part of our work, but please respond in the chat now with what's something you hope to learn from today or take away from today's presentation. And we have some people sharing some information, which is awesome. I'll read some of these out loud. So strategies to support most challenging cases, definitely. One of the things we'll talk about is sometimes behaviors that show up that feel frustrating to us typically come rooted from people's trauma experiences. How to integrate trauma-informed care into substance use treatment, absolutely. Get a better understanding, up-to-date info on these topics. Someone wants to feel more comfortable working with youth, and new methods to implement with youth. Awesome. To be more informed doing my job. How to make more of an impact with young adults and have a better understanding. That's wonderful. Glad to have you here. Yeah, for people kind of chiming in on the chat, it seems like some common themes include feeling more comfortable, being able to help explore and have young people understand their trauma and why they might be ignoring it and how that might be showing up in other ways. Another person for how to integrate with individuals who use substances. Awesome. Awesome. Thanks, y'all, for chiming in. It really helps to have this be more participation heavy. And I know it's just a chat. We're not seeing each other, but that helps because otherwise I feel like I'm just talking to the screen, but I feel connected when you all chime in the chat. So throughout my presentation, I'll pause and have moments to reflect on either a video we just watched or questions for you to ask yourself or consider. So please feel free to chime in, give your input, or ask questions as they come up, and I'll do my best to respond to them in a timely manner, or if it makes more sense to wait, then we might wait till the end. But thanks, y'all, for chiming in. Yep, I appreciate the honesty for those who talked about getting CE credits. But yeah, I hope that this is something that you all find helpful to like walk away with different strategies or approaches that feel really useful and feel like, okay, I sat in this training for 2 hours, but here's this perspective or tool or strategy I can take away with me to help better my approach of working with young adults and just feeling more comfortable in doing this work yourself, because it is something that can feel very heavy and draining at times. So glad you all are here. Let's move over to the next slide. So we're going to talk about why is it important for us to be trauma informed. Trauma is a widespread, harmful, and costly public health problem. So it occurs as a result of violence, maybe abuse, neglect, loss, disaster, war, and other emotionally harmful experiences. Trauma has no boundaries with regard to age, gender, socioeconomic status, race, ethnicity, geography, or sexual orientation. It is an almost universal experience of people with mental and substance use disorders. The need to address trauma is increasingly viewed as an important component of effective behavioral health service delivery. So trauma is at the core of so much of what we might see in the mental health substance use field, and how it comes up is something that needs to be handled in a way with intention, to be really effective to help create better outcomes for individuals who have experienced traumas. So additionally, it has become evident that addressing trauma requires a multi-pronged, multi-agency public health approach, inclusive of public education and awareness, prevention and early identification, and effective trauma-specific assessment and treatment. So I know May is Mental Health Month, and lately I've been seeing a lot more ads on social media about mental health and decreasing stigma. And I think about this the same way in which we might see more of like a medical or physical health disorder and condition being advertised about awareness. What are some strategies or tools of how to know if we might be susceptible to it and what treatment options are? And so thinking about trauma within the same context creates this narrative that destigmatizes trauma and creates space for individuals who have experienced trauma to name, hey, this is something I've gone through. What can I do to work through this, deal with this? What are my options here? So in order to maximize the impact of these efforts, they need to be provided in an organizational or community context that is trauma informed, that is based on the knowledge and understanding of trauma and its far-reaching implications. So just to recap, right, we're talking about why is it important to be trauma informed. I mentioned earlier that a lot of times when we're feeling frustrated or maybe managing some challenging behaviors from people we provide services for, a lot of times trauma is at the core of that. And if we're not paying attention to that, it's almost like walking circles around what's actually going on. The buy-in we need from people like or payers like insurance companies or agencies or that sort of thing is that if we're able to really treat and address and acknowledge trauma and its existence and the implications it has, we're able to help improve people's prognosis, recovery, and hopefully decrease the likelihood for more of those very expensive and urgent needing services, such as a psychiatric hospitalization or intensive outpatient therapy. We really want to make this so that people are aware of what the buy-in is. Why does it make a difference when we're contacting other providers or agencies who are also involved in providing services for young people? In addition to that, the effects of traumatic events place a heavy burden not only on individuals, but their families and communities, and create challenges for public institutions and service systems. Although many people who experience a traumatic event will go on with their lives without lasting negative effects, others will have more difficulty and experience traumatic stress reactions. Emerging research has documented the relationship among exposure to traumatic events, impaired neurodevelopmental and immune system responses, and subsequent health risk behaviors resulting in chronic physical or behavioral health disorders. So what this means is trauma impacts our health, right? So if someone's seeking services in primary care for medical health reasons, it's likely that if they experience trauma, that's going to impact or influence what they may be presenting with, even if they're going there for more of a physical health condition. And even just thinking about my current caseload right now, I could name 2 people that I currently work with who have severe trauma histories, and both have been dealing with both chronic and acute health issues, including cancer or something of the like with risk of it. So to me, it's like, this is really important because if we're not identifying trauma and its role, we might be missing some opportunities to help provide support for people. All right, continuing forward. So individuals with experiences of trauma are found in multiple service sectors, so not just behavioral health. Studies of people in the juvenile and criminal justice system reveal higher rates of mental and substance use disorders and personal histories of trauma. Children and families in the child welfare system similarly experience high rates of trauma and associated behavioral health problems. Young people bring their experiences of trauma into the school systems, often interfering with their school success. And many patients in primary care similarly have significant trauma histories, which has an impact on their health and their responsiveness to health interventions. So one of my colleagues actually works within the primary care office space, so that if an individual comes in for like their regular checkup or their annual exam and they have urgent mental health kind of concerns that they're presenting with, he's able to meet with them and or facilitate a referral to maybe myself or other colleagues, or figure out what resources might be available to them. So public institutions and service systems intended to support individuals may also be trauma inducing. So this is something, as we go to the next slide, I want you all to think about, right? Because we're talking about why it's important to be trauma informed, where trauma shows up, AKA pretty much everywhere: school systems, primary care, child welfare, criminal justice, right? And then the bread and butter of behavioral health. But what do you think about this last statement of public institutions and service systems intended to support individuals are often trauma inducing, right? Because that feels like it's a little backwards from what we're intending to do. But why do you think that might be? Why might, or how might institutions or service systems be trauma inducing? So take a minute, respond in the chat. I want to see what you all have to say about this question I have. And this can be like experiences maybe you've observed, experienced yourself, or ways in which you believe systems may be trauma inducing. All right, great. We got some responses. So yeah, being forced to attend, right, that mandated treatment or therapy. The client may not know how to navigate through their system. Absolutely. I always tell everyone when they say, I'm so confused about my insurance, I say, me too. It doesn't make sense. I don't understand it half the time. And it feels very complex, let alone when we're going through our own stuff too. Another one is use of coercive practices, invasive procedures, and harsh disciplinary practices. Yep. The prison or correctional institution, absolutely. Being in that environment causes many people to judge themselves, triggers person to remember, might feel judged by systems. Absolutely. I've worked with a lot of mandated clients, right? Those that were told you have to go here and do therapy or else X, Y, or Z is going to happen, right? And it's supposed to be a safe place. And at the same time, they feel like their worker is all in their business, or if I say this, what are the implications of that? How is that going to show up in other ways? Agency rules applied to all and not taking an individual's need into consideration. Yeah, so these like blanket statements or policies that maybe are set up so that they're structure, but don't take into account individuals' trauma histories or how that might be impacting them. Feeling a lack of control for the individual, definitely. An environment that does not convey a welcoming place. Yep, we'll talk about that a little bit later, about how to make an environment feel safe or safer for individuals. Overly use of physical force, even in inpatient hospitals. Yep. Let's see. Yeah, we have a specific example here of in settings where people need to be observed for drug screens. This can be re-traumatizing or induce trauma due to previous experiences. Yeah, definitely. Feeling judged or invalidated in their experiences. Prioritizing your plan as a therapist rather than honoring where the patient is at. Yes, thank you for sharing that, Brianna. I think that's really, especially too, as I'll get into working with young adults, it's really important that the person we're working with feels like they have autonomy and feel like we're listening to them and supporting what it is they want to pursue. All right, let me read just a couple more here. I appreciate y'all jumping in and giving feedback. It's really helpful. Let's see. So exposure to other youth or young people who also have trauma and unintended triggers in a shelter setting, reliving their trauma over and over. Everyone has questions and wants explanations. Yep, we'll talk about trauma screening and when we might be able to use them and how to use them with intention. Yeah, having to retell their stories, focusing on symptoms and not addressing root cause of why the behavior exists. Absolutely, right? These are all things that definitely can show up, right? And I think too that like even in naming like these things are happening, it gives us a certain level of responsibility to reflect on what our work is, what our experiences are, and if we're in a place to be able to provide suggestions or create changes, it can really make a huge difference for individuals receiving care to make it be more trauma informed and comfortable so that they're able to get the support that they need. All right, so re-traumatization can occur anytime a person who has experienced trauma is triggered or activated and results in intense feelings, sensations, or memories connected to traumas. Reliving an event connected to trauma can cause significant emotional and psychological damage. So again, it can cause these physical, emotional, or psychological distress. Some of you kind of touched on this before, but these insensitive or seemingly humiliating interviews, testifying in court, especially in front of a perpetrator, visits and confrontations with abusers, family disruptions, separation of siblings, invasive medical tests, fear of safety and police presence, potential exposure to abuse and neglect in placement are all ways in which we need to be mindful of ways that the systems in which are intended to provide support and care for individuals also have the potential to be re-traumatizing. And it's really important to reduce the risk of that for the individuals we serve. Now we're going to kind of segue into the specific population we're talking about today. So if we were talking about kids, adults, and young adults, that would be like a whole week of webinars. And I know y'all didn't sign up for that, so I won't do that for you, do that to you. But this is talking about young adults, so defined roughly by 18 to 25-year-olds, right? The reason why we talk about young adults is because environmental influences can heavily impact mental, emotional, and physical development. There's a lot of changes during teen years, and then this transition into adulthood, also known as like emerging adulthood, right? When we're starting to get our grounding and figure stuff out and problem solve and have our own sense of autonomy. And in my last job working with the first episode psychosis program, this is where this happens a lot of like mental health or substance misuse concerns tend to first emerge at this time frame, right? So this is a population that it's helpful to pay some specific attention to because of that, right? They're more at risk of experiencing mental health and substance misuse concerns, but that also provides an opportunity to intervene early and to try to provide support and information about how a young person might navigate the mental health system or be able to get support around their traumas and help to decrease the barriers that often kind of get in the way from young people being able to get adequate care that they want. All right, so next we're going to go ahead and dive into a video, more so around how young adults can seek help. So these are ways to access services, specific resources, and to normalize the benefits of seeking support.
If you are struggling with difficult emotions, thoughts, or feelings, it's important you get the support you need so you can feel well again. It's going to take a little patience, but here's a few ways you can start. Talk to someone you feel comfortable speaking with, like your doctor, parent, faith leader, teacher, or coach. These are all people who may be able to help you find the resources in your community. Check if your school has a counseling service or workplace has an employee assistance program. In most cases, these services provide short-term counseling or therapy and can help you find a therapist that works with your company or school insurance plan. Join a support group in your area to find other people going through similar challenges you can share your experiences with. And remember, don't keep your feelings inside. You deserve support and help getting through this. If you are struggling with difficult emotions,
All right, what do y'all think about that short, approachable video, as I'll say? I like the kind of beat in the background, that sort of thing, just to kind of make it more normal, like you would see like an ad on social media or on TV, just talking about how to seek out help and support and who might be some resources within a young person's support system that they can lean on. Another resource I like to tell the young people about, especially depending on the state chapter, is NAMI, so the National Alliance on Mental Illness. It's like a really large grassroots organization that, depending on like where you're located, like I know in Chicago, they have a huge amount of supportive services and groups specifically for working with like young adults. But you can sign up and do a peer support group, so with individuals who also identify as dealing with like mental health conditions, but also they have a helpline and they have groups and educational programming for families and loved ones as well, so that they can also get support and further understand what a young person might be dealing with within the context of mental health conditions. All right, so we're going to go ahead and dive into specific considerations for working with young adults. So young adults, or emerging adults as I may call them, typically have been looped in with either adult services, or if they're at the tail end of children's services, might kind of stick with that sort of approach within an agency. However, there's special considerations for needs and concerns with this population. Some of those include more of the logistical and resource concerns, such as transportation, insurance instability, time management, and stable housing. Some concerns about confidentiality, right? So if a young person is accessing resources through like their work resource or their school, they might be wondering who's going to find out, like, how is this going to show up? Is this something I'm going to have to explain? Also, too, I think with like young adults too, who might still be on their parents' insurance plan, they might have questions about confidentiality of like, what would my parents have access to or be aware of? So those are things in order to kind of be mindful of with these considerations for this specific population. And a part that you all touched on earlier, about maybe in a mindset of feeling like there's going to be more punitive consequences of specific behaviors being reported, such as if they say, hey, I've been experimenting with this substance, or engaging in risky behavior, or their sexuality or identity exploration. Those are some things maybe to name when you are working with young adults in order to help to kind of normalize what they may be concerned about, but also to provide information and context as to like what the confidentiality rules and roles are as like a provider. Okay, so I'm gonna encourage you all to think about your own experience of working with young adults, or maybe as a young adult yourself, either currently or previously. Like, what stands out to you? What feels like it was something that would be important for you at that time? Or my favorite question here is, how did you feel about being told to do something? Even now, if someone tells me to do something, I feel like there's that initial pull to be like, well, now I don't want to just because you told me to, right? So in my own experiences with young adults, right, it's that in between, right, of like graduating from being part of like children's services or school systems in which certain things are expected to then adult services. It's like, oh man, you turn 18, you're like, yes, I get to sign my name. And then it's like, oh crap, there's so many things to sign now, and people are asking for this, and I'm getting junk mail about like, I don't know, all these different things to sign up for. It can feel really overwhelming, right? But it can also feel very stressful of like not knowing what our own rights are and not knowing how to navigate these systems. Other parts include developing a sense of identity. So who am I? What do I like? Now that I feel like I have choice in how I spend my time or who I spend my time with, what does that look like? Is this what I want it to look like, or is this what I feel like I just have to do? Clarifying what it means to have autonomy, right? When people maybe are still living with family members, parents, or that sort, it might feel like, hey, I don't have any rights. I don't have the ability to make and choose my own decisions. But how do we navigate that space to help young people feel empowered and to be able to advocate for themselves in a respectful and healthy manner, to be heard and have their needs be met? And then lastly, for this slide, other experiences with young adults is an opportunity to teach competence by doing with instead of doing for. I mean, I know I'm guilty of this, and I'm sure a lot of you, this might resonate too, of like, hey, if I just make this call to the doctor's office and set them up, it'll take like 5 minutes tops. But if I sit there and do the call with them and wait till we meet again, that's at least 10, 15, 20, 30 minutes all in all, right? But the notion of going through these tasks, right, these adulting tasks together with a young person so that they're able to have a safe space in person to work through things with is not only going to feel helpful in like building that rapport and that trust, but also so that long term this person feels more comfortable of navigating those spaces that truly a lot of us don't want to do anyway, but it's part of life. It's part of what we have to do, right? Other people chiming in about experiences with young adults of trusting people to feel heard, feeling understood, being understood. Yeah, and a lot of young people don't feel like they have a voice because they are young and inexperienced. We got someone else saying allowing growth and having patience with the process. Absolutely. We definitely want to promote autonomy, name it, describe it, talk through it, right? Knowledge of what's available to fit their needs. Self-image is important, and letting them grow and learn, and skills and abilities and how to practice them. Being patient and gaining respect. Absolutely. We can go into an appointment with someone and think, okay, here are the things I want to get done today. Let's just move through them, right? Let's just keep pushing and trucking along because I got stuff to do or I've got lunch. And then it's like, wait, let's slow down. This appointment isn't about me. It's about helping to support this younger person And if I'm sitting there and promoting what I think is best, I'm stripping them of their autonomy in a space such as therapy, where it's intended to be able to help support them and give them that sense of, this is your space, it is safe, and I'm going to respect what you have to say. All right, so some additional reflections I've gathered in my years and multiple settings of working with youth and young adults is that patience is so important. Creativity and flexibility are necessary. Being adaptable is truly important. Being our authentic self and use of self is also important, because people know when you're faking it, but especially young people. And that can feel really off-putting to them when they're in a space where they're feeling like, hey, I got to be vulnerable. I got to talk about the most horrible things that have happened to me. And you're going to sit here and act fake or phony. That doesn't sit well, right? And it's not trying to be someone we're not, but it's showing up who we are so we can be authentic and creating space for the young person to feel capable of doing the same. The next one is doing with, not for. That's what I spoke about on the last slide, is really creating that opportunity to learn together and doing it alongside a young person so that they're able to develop a sense of confidence in taking on tasks or roles that might feel intimidating or overwhelming. And then the last one on the slide, talk less and listen more. I always know when I've talked too much during an appointment, when at the end I'm like, oh man, I need some water. I felt like I was going on and really stepping back and pulling back to allowing space, or even sitting in silence, can be really crucial and important to the work that's being done. So in kind of focusing on these traits that'll serve you well of working with young people, so we have patience, creativity, flexibility, and adaptability, it's important to communicate in a way that young people understand. So more effort might be needed in some areas, such as sending reminders, right, about appointments, more communication, providing support with transportation. What are the options? Does your insurance provide transportation? Is there a friend or family member that can help you get to the office? Is it possible within my current system that I meet you in the community at the library so we can knock out some of these case management tasks together? Meeting where they're at might literally mean going to them versus waiting for them to call. Again, it feels like it might be more work in the beginning if we're like, oh, man, like they should just know they have this appointment and show up, right? But we're also teaching a lot of skills that maybe haven't been taught to young people before, or maybe it hasn't been reinforced as an opportunity for them to say, hey, wait, this is important to me. How do I start showing up for myself to reinforce that it is important? Another saying you all maybe have heard, maybe not, is remembering Q-tip. So quit taking it personally. So it's really important to not take specific actions of young people personally, right? I feel like I've had several experiences where I'm like, oh snap, that didn't feel good, or oof, wait, let me reflect. Did I say something that was really off-putting? And it's important to have that self-reflection or even consultation with others, but also to recognize too that we're here to focus on the young person's experience, not what we perceive to be our own failure or insecurities. And I'm a big proponent of, hey, if there's a misunderstanding, I'd much rather we sit there and talk about it and figure out, can we move forward together, versus ignore it, avoid it, or pretend like it never happened, right? Because then we're also diminishing the sense of autonomy. If I'm working with you and I say or do something that you perceive as disrespectful, my goodness, I would way rather have someone come to me and be like, hey, Ashley, this was upsetting to me and here's why, and allow that space to talk through it, versus canceling appointments, not showing, and then me trying to figure out what happened, but not getting any sort of response from a young person. We're humans, right? We make mistakes, but if we can create a safe place to work through disagreements or different understandings, it also creates like some sense of safety too for a young person to have a healthy disagreement and work through it with someone who cares and who won't just disregard what they're saying or discard them as a client or a person. So some common traps that take away from being youth-driven. So it does take skill to facilitate a conversation that prioritizes another person's perspective and priorities. And this can be particularly true of conversations that are intended to be youth or young adult driven. Even providers who value youth-driven practice can unintentionally insert their own perspective into conversations with young people. So though all of these on the slide there are likely to come with the intention of helping or supporting the young person, they are ultimately detrimental to the relationship between the young person and the provider and limit the young person's opportunity to build skills and confidence in the long term. So some of these things, and mind you, let's just normalize that. I'm guilty of all of these and I love being youth-driven, but I'm human and these are important things to be aware of. If you want more specific details on how this might look, this is in the resources that Achieve My Plan Plus, where it gives different prompts and things you can consider. But here are the main traps that happen that take away from that youth-driven conversation. So it could be leading the conversation too much, making suggestions, offering advice, favoring one of the young person's ideas over another, and asking leading questions. So these are all things to consider in our work of, are we kind of replicating a parental role of, well, you could do this or that, but I prefer you do this, or offering advice when that's not what they're looking for, when they just want to be heard or have space to vent and talk about things. Or if we feel like, hey, we got to talk about X, Y, and Z today. So you might be bringing up stuff about family, but I'm like, we got to talk about you doing this over the weekend, and pushing that really strips away from being youth-driven in that moment. All right, so next we're going to go into a video that really talks about how we can recognize people as whole beings and bring awareness to trauma and its impact, and moving from a place of treating someone to being more healers. We'll get the video started in just a moment here.
How can you ask someone about their body? How can you ask somebody about their mind and not recognize their experiences in the world as they're living in that body, as they're thinking and having that mind? It really is about recognizing people as whole beings and not just body parts. To me, that's trauma-informed care.
The majority of illnesses and conditions that people are treating in primary care settings are trauma-related.
There are things going on inside that you cannot visibly see, that if you don't ask about, it's maybe a barrier to the actual care that the healthcare system wants to provide.
We want to give people good care, but we want them to thrive. Not just be healthy, but thrive. And it's very hard to thrive in this community.
I experienced patients that were behaving in ways that were really stressful, cursing, yelling, really heightened emotions at the front desk, in my office, breakdowns. We might naturally ask ourselves, what is wrong with that person? Trauma-informed care is really about saying, what happened? Why would a person behave that way? I think one of the biggest frustrations that I've seen from my medical colleagues is frustration. Like, oh my gosh, I keep telling this patient the same thing over and over again. How many times are they gonna come in, not listen to what I recommend, and then have the same symptoms and then keep coming back for the same symptoms? If we ignore trauma in our practices, what we're gonna end up doing is doing the same work over and over again without having a different outcome.
I mean, our experience as providers has changed from being overwhelmed, from having a chaotic clinic, to an experience where we're feeling like we are doing the absolutely best job possible.
People come willingly. They're using more services, so they're understanding that their health is not just that medical service, but it's what they eat, how much you move, and the state of your soul.
But what we've seen is people kind of having longer periods of stability, and maybe they slip, but they get back in touch with us more quickly than they used to.
Once you start communicating where you're not being dictated to, you know, someone is actually asking you, how do you feel about this? And how, you know, it builds that trust. You know, it's like, wow, they actually heard me, you know, and I see it.
Talking about and becoming trauma-informed does not have to be a traumatic experience.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
All right. What did y'all think about that video? From treaters to healers, anything stand out? I know as I'm watching it again, not for the first time, but like this this notion of reframing this narrative instead of what's wrong with you to what happened to you, right? And I know I've mentioned this throughout the training today, but those frustrating behaviors like that person was describing, like a client yelling or showing aggression, can be rooted from trauma. And if we're able to change this narrative, not only is our relationship with the patient going to change, but that's more likely to improve patient engagement, thus create better outcomes for them, right? Um, yeah, some other people are saying joy is important. It's everything. It's important for medical, taking an individual's past history of trauma into account. Yeah, Christy, the state of your soul. Yeah, there was this woman that said it's also about what you eat, how you move, and the state of your soul, right? Made me realize there is more I can do to extend my understanding and empathy to empower and honor autonomy. That's powerful. Wow. Yeah, thank you. Thank you all for this. I think that, you know, we get into these professions or these roles that bring us to trainings like this today, right? And like that person was saying, it's not radical to think we want to help people heal, right? But sometimes within the limits and confines of different time constraints or policies or practices, right? It kind of teaches us out of it and makes us just want to do the thing that makes us quickest and most efficient at it. But even thinking about what we do now and the long-term impacts, even if we take a step back and be able to help be more trauma informed and create an environment that helps create healing and change, really in the long term, we're also helping to save time, right? If an individual doesn't need to keep seeking out treatment and support in order to feel like they can heal from their traumas and their experiences. All right, so as providers grow aware of trauma's impact, they are realizing the value of trauma-informed approaches to care. So trauma-informed care acknowledges the need to understand an individual's life experiences in order to deliver effective care, and has the potential to improve engagement, treatment adherence, outcomes, and provider and staff wellness. A set of organizational competencies and core clinical guidelines is emerging to inform effective treatment for individuals with trauma histories, but more needs to be done in order to develop an integrated, comprehensive approach that ranges from screening persons for trauma to measuring quality outcomes. So we'll keep talking through about how this can be changed and discussed within an organizational and clinical perspective. All right, I'm going to keep going along, but if any of you need to kind of take a moment and get up and get some water, go to the bathroom, do your thing, but I'm going to keep going forward so that we can end a few minutes early, but please take care of yourself if you need to. But yeah, so we're going to go onward here. So as healthcare providers grow aware of trauma's impact, they are realizing the value of trauma-informed approaches to care. So trauma-informed care acknowledges the need to understand an individual's life experiences in order to deliver effective care, and has the potential to, again, improve, improve engagement, treatment adherence, outcomes, and provider and staff wellness. So to kind of take a moment to break this apart a little bit, is not only when we're talking about trauma-informed care, are we focusing on helping that individual and their services, but also to that last part about provider and staff wellness. I don't know if you all recall, but in that video where that lady was saying something along the lines of, how many times do I have to keep saying this to the same person before they're willing to make a change or adjustment? If we're able to shift our approach slightly and make it so that what we're saying or doing better lands with the person we're working with, it's going to improve the well-being of the staff providing the services, because not only are we likely to have better outcomes, but also too, seeing people heal and get better is something that's rewarding, and that brings us into the work that we do, right? So if we're able to see this kind of play out and happen, then that's going to help kind of keep that momentum going and moving forward for us. Right. Oops. Sorry, I got ahead of myself there. Okay, so trauma-informed care, again, seeks to understand and recognize the impact of trauma on patients, families, and staff. And it's better to not assume, but rather try to be curious and clarify how it shows up for an individual, right? And then if we're working with a young person, let's say a young adult, but who still lives at home and they're experiencing different behaviors or symptoms as a result, how is the family responding to that? And does the family feel like they have the support and tools to help guide that young person into healing and recovery? We want to integrate knowledge about trauma, both at a macro level, so more of organizationally, but also in our direct clinical practices, and to actively avoid re-traumatization. So there's that slide now. So I want you all to think about a name in the chat box, specific ways you maybe or your agency are currently trauma informed. What are some things you all do in order to be trauma informed in your work or just as an organization? All right, so we have operate from a person-centered approach. Definitely, this can be even down to how we write and frame our goals and using the individual's own words versus our own. Our intake paperwork addresses ACEs. Thank you for that, Stacy. We'll be talking about ACEs here very soon. Jenna's going to trainings, becoming more knowledgeable, absolutely. Listening, yeah. Practice compassion and understanding, more webinars and trainings. Yep, definitely exposing ourselves and picking up different elements and components in order to kind of help us add to our own toolbox. Identifying with the client. Clinical meetings, provide staff feedback. Yeah, having that open dialogue is so important too, to be like, wait, here's what's going on. Here's what I'm doing. Is there more I can or should be doing? And what is the client saying about my approach? Recognizing signs. Yeah, required trainings on trauma, supervision to discuss these topics. Absolutely. A lot of y'all are mentioning different trainings, but also this accepting people where they're at, being patient and consistent. So this is great. Kathleen mentioned in their work of maternal and child health division, they all complete ACEs with their clients and have been trained in trauma-informed care. Oh, and y'all do home visits to pregnant women and children. That's awesome. Yes, Quincy, decreasing access barriers to support. So we want to make things readily available to young adults, right? Using empathy skills, giving them space to talk freely and creating that safe place, right? Especially when we're talking about trauma, we got to recognize too that someone might not feel completely and totally safe, but if they feel safe enough to start exploring what's happened or how they want things to look for them in their life, that's still a win for us. Awesome. So yeah, a lot of compassion, continued support. A trauma department with therapy, including EMDR. Awesome. Y'all are doing a lot of trauma-informed work already, and I hope that today's training also adds to what you all are already doing, right? Because the idea here is like you all are really engaged in working with young people or doing trauma-informed work anyway, and so being able to add to that, but also share resources is really awesome and important. All right, so let's keep things going forward with some key ingredients for creating a trauma-informed approach to care. So this must involve the buy-in from organizational and clinical practices that recognize the complex impact trauma has on both clients and providers. Well-intentioned providers often train their clinical staff in trauma-specific treatment approaches, but may neglect to implement more broad changes across their organizations to address trauma. Widespread changes to organizational policy and culture needs to be implemented for a setting to become truly trauma-informed. Organizational practices that recognize the impact of trauma reorient the culture of a care setting to address the potential for trauma in clients and staff, while trauma-informed clinical practices address the impact of trauma on individuals served. So here are some examples of more organizational perspectives of how to create a trauma-informed approach. So leading and communicating about that transformation process, engaging individuals in organizational planning. The last place I worked, we actually had a youth and young adult advisory board that were able to facilitate their own meetings with outcomes and to be able to present them to the board of directors in order to have a say over what's happening within the program and the organization as a whole. And I thought that was really powerful way to show and reinforce young people having a voice and having autonomy. Next one is not just training clinical staff, but also non-clinical staff as well. So people who have a lot of interface with clients are often non-clinical staff, administrators, those who welcome the people at the front desk. Those sorts of roles are also important too. Creating a safe environment, we'll give a little more details a little bit later on. Preventing secondary traumatic stress in staff. So again, we're not just talking about the people in which we provide services to, but also being mindful in working with trauma, that vicarious trauma is real, and it's something we need to be aware of and mindful of to provide the staff the necessary support and skill sets in order to decrease that likelihood of experiencing secondary trauma, and if they do experience it, feeling comfortable in how they might be able to navigate that. And then lastly for this slide is hiring a trauma-informed workforce. All right, next we're going to go into more of the clinical perspective. So this includes involving individuals in the treatment process. So this is what's going on in these services, what do you want to happen, what are your preferences, are you someone who prefers meeting virtually or in person? Are there certain days of the week where that's easier to meet for you because you have a ride, you have transportation? And if those things are workable, let's make it easier for this young person to get support. Next is screening for trauma. We'll talk about the ACEs here soon. Training staff in trauma-specific treatment approaches. I know several of you have mentioned EMDR as a trauma-specific treatment. That's a great resource. And then engaging referral resources and partnering organizations. So again, it's that multi-pronged, multi-agency approach and being able to connect the dots and pieces so that we're providing more informed care and more likely to have those outcomes and recovery and prognosis improve for the people in which we're providing care for. Okay, so some core principles of being trauma-informed include empowerment. So using individual strengths to empower them in the development of their treatment. So I was kind of talking about this, but like, what do you need? How do you want to experience that? If there's someone who maybe is really uncomfortable sitting with someone they don't know, is there a way to make it feel more comfortable? Let's start off by meeting for 30 minutes or 15 minutes. Then we're going to check in, see how you feel. What are your options, right? Which leads us into choice. So informing individuals about treatment options so they can choose the options they prefer. So this is not just based off our own preferences as a provider or what interventions or therapy you just got trained in, but we must get people's consent for the treatment we are providing. So like within the last year, I've gotten trained in EMDR therapy. And while I'm excited and wanting to implement that in my practice, I can't just go into an appointment and be like, all right, here we go. This is what we're doing, right? I need to get a person's consent to do that treatment and talk about the potential implications of that treatment in order to get their buy-in and to ensure that that's something that they want, not just because I'm eager and excited to use these new tools and strategies, right? Next is collaboration. So this is maximizing collaboration among staff, clients, and their families in organizational and treatment treatment planning. So this might take more time, but it's in their best interest, right? And it's more of that investment of like, this can pay off later on, both in their own recovery, but I also think about too, in my last job, we rotated being on call for our crisis line. And when I took more time to talk with family members or those the individual identified as family or support people, about what was going on and what a crisis looks like and what options they have to support their young person. I noticed that they were the families or individuals less likely to call the crisis line because they felt empowered to manage those situations and know what resources were available to them, but also to know like the warning signs and symptoms that would come up, right? So again, it's important for us to be trauma informed because it makes the care we provide more beneficial for all of those involved. Next is safety. So we're developing care settings and activities that ensure persons' physical and emotional safety, trustworthiness, creating clear expectations with individuals about what proposed treatments entail, who will provide services, and how care will be provided. So these attributes form the core principles of a trauma-informed organization and may require modifying mission statements, changing human resource policies, amending bylaws, allocating resources, and updating clinical manuals. And these are just things that we need to be mindful of, that while some of these things on a more organizational level might take some time, effort, and advocacy to make changes to, there's also ways in which we can start that process by the work that we're doing within the clinical context. So people with histories of trauma might feel unsafe in unfamiliar environments, leading to some anxiety or stress, and minor changes to a provider and or healthcare organization's physical, social, and emotional environment can improve patients' feeling of safety and create an atmosphere that reduces the likelihood of re-traumatization. So when we're talking about creating a safe environment, here are some things maybe to consider. So keeping parking lots, common areas, bathrooms, entrances, and exits well lit. Keeping noise levels in the waiting rooms low. I was at a recent training focusing on schizophrenia, and there were some ER doctors talking about it. And a lot of times when people come into the emergency room to be assessed for psychiatric hospitalization, there's so much noise and commotion and chaos happening outside of the rooms and within the emergency department that it really doesn't create like a very safe feeling or cohesive place for the person who might be experiencing more acute distress, right? But in our waiting rooms, are we able to keep noises low, make it so it feels more comfortable for a person waiting in there? Next is using welcoming language on all signage. Also to be mindful of populations and making things available maybe in other languages too. Ensure staff maintain healthy interpersonal boundaries and can manage conflict appropriately. So not just assuming that someone might be okay with or comfortable with eye contact, or as you're walking down the hall to your office, how close to stand to that person. Those are things to take into consideration because, again, we don't want to assume it's going to be a certain way. We want to be mindful of each individual's experience and asking for consent for that. Or even I had someone who recently had an injury and they were using one of those, I think they're called like knee scooters for their injury. And I asked permission, hey, is it okay if I open the door for you and help like get you out the door by doing that? And they said yes. But it's like just being mindful of those things instead of just assuming, hey, I'm doing a nice thing, it's all good. I want to make sure that that person that I just met knows, hey, I'm thinking of you in this. Is this something that you feel okay with? So continuing onward with the creating a safe environment also might include offering sufficient notice and preparation when changes are necessary. So schedules and procedures. I know there's a few clients I have in particular who, if we need to be meeting one week at a different time than our usual Tuesdays at 5:30 or Wednesdays at noon, I have to give them ample notice to be aware of and to give time to adjust to, because otherwise things could feel really thrown off for them and their schedule. Next is maintaining open, respectful, compassionate, and consistent communication, right? So if I'm someone who typically responds to emails or messages within 24 to 48 hours, but someone calls and I don't respond at all, that might feel a certain way for that person who's used to me showing up in this certain way with them and being responsive. So it's just small kind of areas to be aware of, that even if it might not feel like a big deal for us, if it's a change or a disruption in our approach, it may be interpreted in a way that might create a feeling of unsafety, or just feeling like, hey, something's going on, Ashley didn't respond to me. That feels very concerning, or I'm wondering, does she not want to work with me anymore? And I could have been out on vacation and just forgot to put my out of office message on, right? So lastly here, being aware of how an individual's culture affects how they perceive trauma, safety, and privacy. So again, we want to help take inventory, clarify if we don't know, and be able to be really curious about someone, so we're not making assumptions and basing it off of our assumptions, right? Why not give that person a chance to share their own preferences and what they're comfortable with? All right, so we've just gone ahead and talked about different ways in which to make either your own clinical practice or organizationally more trauma informed. So out of the ones I talked about, ones you've seen from other people in the chat, what's a strategy you feel like you could implement on a clinical or, again, organizational level to be more trauma informed? Because what I saw in the chat earlier, you all are doing a lot of trauma informed work, but what if any of the ones that I mentioned stand out to you? Or are there certain barriers you'd foresee kind of getting in the way of being able to implement and be more trauma informed? Feel free to throw that in the chat so I can get a sense of what you all are thinking might be a helpful or useful strategy you might implement after you leave today. All right. We have sharing information from webinars or trainings with coworkers. Yes, absolutely. Could be as simple as, hey, I went to this webinar today. They talked about how to create a safe environment, and I realized, like, we have a really creepy door that leads to the parking garage. I wonder if there's something we can do to make it feel less creepy, right? Even those conversations in those team meetings, just bringing it up and seeing what other people have to say. We also have someone saying getting the patient or client input to make the environment comfortable and what is expected or wanted coming into their environment or community. Yeah, absolutely. Absolutely, especially if we're providing home visits or meeting them in their community. What are they okay with? What are they thinking is going to happen? And what are some expectations we can talk about on both ends with that? Sharing modalities like seeking safety with coworkers. Yep, absolutely. Complete trauma-informed care days for our team or a yearly retreat. I love that idea, right? Not just pretending like vicarious trauma doesn't happen, but actually creating days or certain times of the year to say, hey, y'all do a lot of heavy duty work where you're exposed to secondary trauma. Let's create space to sit with that and provide support. That's awesome. Keeping noise down in other rooms. Yeah, my office currently is right next to the break room. And sometimes mid-session, I want to tell people, like, no, can you step out of that office when I have a session, right? Because if I have someone who might be really hypervigilant, right, and not feel safe in a lot of places, and there's a lot of noise coming from the room next door, sometimes I notice it's so distracting that a person might not be able to focus on the session anymore because there's a threat of safety. because they're hearing noises but not being able to see what's going on there. Creating safer environment for staff. Okay, yeah. Learning via trainings like this, being mindful of personal space, proximity, noise levels, lightings, absolutely. I don't use overhead lights in my room because they give me a headache, so I just use lamps. But I'm always mindful of asking people when I'm first meeting with them, how do you feel about this lighting? Is this comfortable? Do you want more light? Raymond said that they're trying to make their facility more warm and welcoming. Awesome. Also trying to streamline the process so clients do not have to share their story with different therapists as they go through the program. Yeah, that's wonderful. More of how do we collaborate and make things feel more streamlined and smoother for people and for those providing the work too. Absolutely. Light covers in school settings to help those who are overly sensitive. Those are awesome. Yeah. Updating spaces clients spend the most time in, like waiting rooms, offices, to feel more welcoming and private. There was one office I worked in that they had like giant beanbag chairs in their therapy rooms as like an option for people to sit in, and I thought that was super youth focused. They also had like a ping pong table in like the community room, so people could engage in games and stuff when they had different events or as they're waiting for their appointments. Absolutely. Thanks y'all for chiming in here. Yeah, I think noise levels, being mindful of proximity and boundaries to people, making sure our own offices are calming and comfortable, and asking too about expectations from a person and ensuring that they feel comfortable enough in the space that we're sharing. And if not, what are some adjustments that we can make? All right, so we're going to kind of dive into some risk factors, and this leads us into talking about ACEs as well. So some common risk factors for development of mental health conditions and substance misuse disorders in youth and young adults can include abuse and neglect, death of a loved one, and community violence, among others, which can lead to serious mental and physical health concerns. So ACEs include experiences that have long-term impacts on youth who experience them. So some examples of that include different experiences of abuse or neglect, growing up in a household with substance misuse and or mental health concerns, instability due to parental separations, a household member going to jail or prison. Youth who experience ACEs, especially those who experience multiple ACEs, are more likely to suffer harmful long-term consequences, such as major depressive disorder, a substance use condition, or physical conditions like obesity and high blood pressure, when not met with an understanding and trauma-appropriate response from adults. So instead of diving more into ACEs on that, and I want us to go into this video that describes an individual's own personal story of adverse childhood experiences, and you'll hear about the connections that she had between ACEs and physical health conditions. So let's listen.
I came to the United States when I was 12, and prior to that, living in Nigeria, abuse was very normalized. I was told that my face was not worth looking at. My voice was not worth being heard. My experiences made it very painful for me to look people in the eye, and I was forming scoliosis on my back because I bent my head down. And I never looked up. I realized that I was hiding my brokenness because I was just so afraid to show it to the world.
You were not broken, you were injured. It's a big difference. Injury is something you can heal from.
The term ACEs stands for Adverse Childhood Experiences. And it actually comes from a study that was done by the CDC and Kaiser Permanente now over 2 decades ago, in which they asked adults about their history of 10 categories of adverse childhood experiences. And these include physical, emotional, or sexual abuse, physical or emotional neglect, or growing up in a household where a parent experienced mental illness, substance dependence, incarceration, where there was parental separation or divorce, or intimate partner violence. And what they found in that big research study was that for someone with 4 more ACEs, their risk of heart disease was double, for stroke and cancer and liver disease and diabetes, even autoimmune disease. There's a direct, what we call a dose-response relationship between adverse childhood experiences and some of the most significant and serious health conditions that are facing Americans today.
I wish my provider knew when I was 14 going to the pediatrician office and I was forming scoliosis on my back, what's happening to this girl. I would have had a different outcome.
ACEs Aware is all about supporting our healthcare providers with the resources, the research, the data, the information, the protocols on how to screen and how to do it in a way that's evidence-based and trauma-informed. The data is clear. Early detection and early intervention improves outcomes. One of the things that I say often is that we have to put our own oxygen masks on first. How has learning about ACEs impacted how you approach your role as a mom?
I watched my father fight his ACEs. He didn't have the time to be vulnerable or the resources to support these battles that he was fighting in his head, the battles that I was fighting for a while until I had access to resources such as therapy. Because of that, that trauma was transferred over to me. This work helps you understand that intergenerational transmission of ACEs. And my understanding of that gives me more power to ensure that my son doesn't have the same ACE score that I do.
It's never too late to begin healing from ACEs. What this information, what the science does, is that it gives us tools to be able to determine our own futures.
All right. Any thoughts or comments on this video? I know some of my takeaway from it is how important early detection and early intervention is to improve outcomes. Also, what she was talking about is the impact of how she parents and changes or disrupts this pattern of intergenerational trauma, right? And that's never too late to heal from ACEs. And I think it's important to have different contexts, right? Of like what ACEs is outside of the screening tool and how it can help inform people so that they feel empowered to move through what it is that they've dealt with or been experiencing. So I'm glad you all found it to also be powerful and touching. I just think like there's only so much I can say, but hearing from someone's personal experience also is really beneficial. Right. Oh yeah, and having to place your own oxygen mask on first before helping others. I know that's all airplane stuff talk too, but I think that's also very important. And I think that's what she was describing as well, of taking care of herself so she's not passing on certain things to her son. Okay, so ACEs and other trauma screening tools, we want to kind of just mention that trauma screening, it's recognized as the most fundamental aspect of a clinical trauma-informed approach. But some experts differ on when and how to screen individuals from trauma. So the two kind of differing approaches are the upfront and universal screening, involving screening every person for trauma history as soon as possible. So the proponents of this approach assert that it allows providers a better understanding of an individual's potential trauma history, can help target interventions, provides aggregate data, and quantifies the risk of chronic disease later in life. Universal screening can also reduce the risk of racial and ethnic bias by screening all patients or clients. Furthermore, a person can be asked to share a cumulative ACE or other screening score after completing a questionnaire, rather than having to identify specific traumatic experiences, which allows them to decide how much detail to provide. The second approach would be those who are opponents of the upfront screening. They feel that patients or clients should have the opportunity to build trust in providers before being asked about their trauma history. Those who favor later screening for trauma contend that upfront screening removes the individual's choice of sharing sensitive information, can re-traumatize a person, and may hinder progress if there are not appropriate interventions or referrals in place. So I'm not here to say one way's right, one way's wrong, just different things to take into consideration if within your agency you're taking the upfront and universal screening approach, or if you're taking the approach of let's wait and see what could benefit the client, and being mindful then about connecting appropriate interventions or having referrals in place if you are to go that route. Some other considerations include thoughts about rescreening and trying to avoid that. So if we're frequently rescreening individuals, that may increase the potential for re-traumatization because it requires them to visit their traumatic experiences. So minimizing screening frequency and sharing results across treatment settings with appropriate privacy protections may help to reduce rescreening, right? So if we just got someone as a referral from another agency and they identified this person as having a trauma history and already did the ACEs, if we have a signed release of information form, why would we not try to get that screening that was just recently done, as opposed to having this person have to repeat that over and over again? Some other screening tools, such as for generalized anxiety or for depression, some of those make more sense to check in around symptoms in 3, 6, or 12 months. But this is more so talking about rescreening frequency with ACEs or other trauma screening tools. Is just being really mindful and intentional about it, and also to be able to offer that as a choice for the person, and also have some sort of like information as well about being able to say like, hey, this is what this is intended for. Here's how I think it could help inform our work together. Is that something you're willing and able to do? Or is this something you want to hold off on and we come back to later? So again, it's about that collaboration and being able to provide choice. All right. Can you all still hear me? Let me see. Yes, okay. Cool. I think one of my headphones died, so I'm just gonna keep going, but if the other one goes out, please let me know as soon as possible. Okay, so moving onward with the ACEs. So ample training should precede screening. So all care professionals should feel proficient in trauma screening and conducting appropriate follow-up discussions with individuals that are sensitive to their culture and ethnic characteristics. So language, cultural concepts of traumatic events, right? I think about this as like, if I went to the doctor and they're doing this exam and like looking into stuff and they're like not really feeling confident doing that, it's gonna make me feel uneasy, right? So thinking about trauma and it being some of the most vulnerable parts of us coming up, we wanna make sure we feel comfortable enough, not just presenting the screening to the person, but being able to ask those follow-up discussion questions with them, providing context as to why it is we're doing that and being able to move through it. Because if we're not feeling comfortable doing that, I don't feel like that's the best fit for the person that we're providing services for. We might need to look at other approaches or strategies that might be more beneficial for them. All right, before we move on from the ACEs, if anyone has thoughts, questions, or concerns pertaining to ACEs, feel free to throw them in the chat right now. Otherwise, we're gonna move into this other component that we're leaning into as well, that also focuses on more protective factors and individual strengths, right? Because we want to move that conversation from what's wrong with you to what happened to you, but also what are your skills and strengths that really help make you who you are and can help you be able to move through your life in a way where it brings quality of life and value. So by definition, protective factors are characteristics associated with a higher likelihood of positive outcomes or those that reduce a risk factor's impact. Protective factors may be seen as positive countering events or actions. Individual level protective factors might include positive self-image, self-control, or social competence. So when I think of protective factors, right, we're kind of looking at ACEs that like might make someone more susceptible to experiencing mental health or substance misuse conditions, but these protective factors can help create that balance to almost give a person some advantage to be able to fight or work through things that they have experienced. And I think too, like in a lot of places, not just in behavioral health, but in primary care or in school or in other systems or settings, like there tends to be a lot of awareness to like what brings you in, what's the problem, what are we working on, but more attention and awareness to, hey, what makes you you, what's important to you, and how do we utilize that for our work together, not only empowers the person that we're providing services for, but it's also more likely to create those long-term, long-lasting changes for this person because it's about them and we're pointing out and bringing to the surface things that they contribute and bring to the table that they might not be aware of or they might not recognize as a strength. Okay, so although we've learned a significant amount about the benefit of positive experiences, most practitioners and researchers still tend to focus on the negative. Though screening for trauma and signs of danger in the home are both vital, focusing exclusively on these areas prevents a holistic view of patients and clients. So positive childhood experiences drive healthy development and mitigate the long-term effects of adverse childhood experiences. Research shows that these experiences can promote children's long-term health and well-being, enable children to form strong relationships and meaningful connections, cultivate positive self-image and self-worth, provide a sense of belonging, build skills to cope with stress in healthy ways, and really positive childhood experiences protect future adult mental health. So the more positive childhood experiences you have, the lower your likelihood for depression and poor mental health in adulthood. So in 2017, a paper published in Academic Pediatrics established 4 building blocks, which describe the type of positive childhood experiences that are critical for healthy development. Every adult who interacts with children and families has the ability to promote access to these building blocks to create a thriving community. So don't underestimate your presence in someone's life, even if it is a mandated service or residential or a facility where maybe they don't want to be. We have the ability to help promote access to these building blocks. So these 4 building blocks include relationships, environment, engagement, and opportunities for social and emotional growth. So I'll go through each of these quickly. So relationships include nurturing and supportive ones. Early secure attachment, so the bond between baby and parent, are seen as critically important. Supportive relationships outside of parents, this could include other adults and peers. Environment, safe, stable, and protective, and equitable environments to live, learn, and play. So not just talking about safe and stable housing, but also adequate nutrition, access to good quality healthcare and education, but also safe and appropriate places and opportunities to play, because remember, it's about joy. Next is engagement, so connection to the community, feeling of belonging and that they matter to the people and communities around them. Community projects or events, helping teachers at school and tasks at home can help children feel valued and connected. And then the last building block is opportunities for social and emotional growth. So development of social and emotional competencies, navigate adversity and challenges constructively. So my example about, hey, if we have a disagreement, let's talk through it. That could be an example of this. And an example of unstructured playtime with peers can allow children to learn how to negotiate and settle arguments in an appropriate manner. So something to take into consideration in the work that we do, and being mindful about the impact that this can have on young people. So next we're gonna do our last video for today, but it's gonna dive into the toxic stress response and ways to heal from it. And then after that, we'll start to wrap up about trauma-informed approaches.
The term, the toxic stress response, actually refers to the prolonged activation of our body's stress response, the release of all those stress hormones like adrenaline and cortisol and all of those things that go along with our stress response. And then also the ways in which that affects our bodies. Children are especially vulnerable to this repeated activation of the stress response because their brains and bodies are just developing. So high doses of adversity in children actually changes the way their brains develop. It changes the way their hormonal systems develop, their immune system develops, and even the way their DNA is read and transcribed. And those long-term changes are what we refer to as the toxic stress response. When we understand what happens in our bodies with the toxic stress response, and we understand that it's that prolonged activation of our stress response, then step one is really understanding what are the things that help to regulate our stress response. And immediately at that point, we begin decreasing the harm that happened as a result of our past experiences. So things like mindfulness, right? Meditation, spending time in nature, mental health interventions, regular exercise, nutritional strategies, and my favorite, healthy relationships. All of these things are really scientifically demonstrated to help to regulate the biological stress response, and they improve our outcomes for those of us who have experienced ACEs. These nurturing relationships, they feel good, which is good, of course, but they literally change our biology. When we have safe, stable, and nurturing relationships in our lives, it improves our neurologic functioning, it improves our hormonal regulation, it improves our immune functioning, and these social supports are critical part of healing. If we all understand our role in being a source of buffering care to a young person in need, that is truly transformative. ACEs are not destiny. Even if someone has experienced significant ACEs, it doesn't mean that they are absolutely going to have these negative outcomes. Recognizing our ACEs requires us to recognize our vulnerability. And that can be really scary. But it also is the place where we get a chance to ask for what we need. I deeply believe that we can cut ACEs and toxic stress by half in one generation.
All right. I hope y'all are feeling really motivated and empowered to move forward and do this work. Just a couple more quick slides. Also, this is my pup Willow. I like to include her on my webinars if I can. So if you've done a training with me before, you might recognize her. So from SAMHSA's perspective, it is critical to promote the linkage to recovery and resilience for those individuals and families impacted by trauma. So consistent with SAMHSA's definition of recovery, services and supports that are trauma-informed, build on the best evidence available, and consumer and family engagement, empowerment, and collaboration. So I'll go through these 6 key principles that are fundamental to trauma-informed approach. First is safety throughout the organization. Staff and the people they serve, whether children, adults, young adults, feel physically and psychologically safe. The physical setting is safe, and interpersonal interactions promote a sense of safety. Understanding safety as defined by those served is a high priority. Next is trustworthiness and transparency. So ensuring that organizational operations and decisions are conducted with transparency, with the goal of building and maintaining trust with clients and family members, among staff and others involved in the organization. Third is peer support. So peer support and mutual self-help are key vehicles for establishing safety and hope, building trust, enhancing collaboration, and utilizing their stories and lived experiences to promote recovery and healing. The term peers refers to individuals with lived experiences of trauma, or in the case of children, this may be family members of children who have experienced traumatic events and are key caregivers in their recovery. Peers have also been referred to as trauma survivors. Number 4 is collaboration and mutuality. So the importance is placed on partnering and the leveling of power differences between staff and clients among organizational staff, from clerical and housekeeping personnel to professional staff and administrators. So demonstrating that healing happens in relationships and in the meaningful sharing of power and decision making. The organization recognized that everyone has a role to play in trauma-informed approach, As one expert stated, one does not have to be a therapist to be therapeutic. Number 5, empowerment, voice, and choice. So throughout the organization and among clients served, individual strengths and experiences are recognized and built on. So again, we're recognizing the history of power differentials in ways in which clients' voice maybe have been diminished and there hasn't been a lot of choice with different treatments. So clients are supported in shared decision-making, choice, and goal setting to determine a plan of action they need to heal and move forward. And they are supported in cultivating self-advocacy skills. So staff and facilitators of recovery rather than controllers of recovery. So we're facilitators of recovery. We're not trying to control it, we're trying to help facilitate it. And that also staff feel empowered to do their work as well as possible by adequate organizational support. So this is a parallel process, as staff need to feel safe as much as the people receiving services, right? Lastly here, cultural, historical, and gender issues. So the the organization actively moves past cultural stereotype and biases, offers access to gender responsive services, and leverages the healing value of traditional cultural connections, incorporates policies, protocols, and processes that are responsive to the racial, ethnic, and cultural needs of individuals served, and recognizes and addresses historical trauma. Whew, that's a lot, y'all, but this is really, really important work. And in the interest of time too, I just want to quickly go over this next part, give some strategies of different treatment approaches that are trauma informed. I know someone in the chat mentioned using seeking safety, which is on here, EMDR, but also prolonged exposure therapy as well. Quickly go into a few resources. So Hope Florida was not one I knew about, but I was informed about, and this is a really great service that provides kind of like access to working through some barriers that might come up to receiving support and services. And I think too, for the young adult population or children aging out of foster care, this can be a really great resource. So services are provided by Hope Navigators, which I really appreciate that title, right? So their job is to help identify goals and barriers, referrals to local and community-based partners, and provide that one-on-one support to develop a plan to help achieve economic self-sufficiency, right? So it's doing with, not just doing for, to help sustain long-term impacts. And then this last resource I'll talk about is suicide prevention. So when people call, text, or chat 988, they'll be connected to trained counselors that are part of the existing Lifeline network. So these trained counselors will listen, help to understand how an individual's problems are affecting them, provide support, and connect them to resiliency resources. So suicide-related thoughts and behaviors are a major public health priority that impacts everyone, individuals, family members, friends, and communities. And as the 12th leading cause of death for all Floridians, prevention and intervention efforts are focused on decreasing risk associated with suicide and increasing coping mechanisms for individuals and their community. So really sharing this resources could be a matter of life and death. Even if someone doesn't endorse having suicidal ideation, it might be the resource they're giving for themselves or someone else that could really help them in their moment of need. So lastly, I like to put this slide up. Okay, so as you wrap up for today, I just want you to think about or consider what's the most important thing you learned from today, what's one thing you plan to implement, or something that you're already doing well. Again, we want to focus on your guys' strengths and what you bring to the table, but also be mindful too of the work that you do, and being able to give yourself some credit, but also take what you can from this presentation and implement it in a way that feels meaningful. So before I hand it over to Robert, I just want to thank you all for what you do, for taking a couple hours out of your day this Wednesday to join me. Y'all are doing great work and already really trauma informed. So I hope this just adds to what you're already doing. Thanks to Eric and Robert for your support, FATA, Florida Department of Children and Families. And again, thank you all for attending. Really appreciate your participation. You all are wonderful, and I will hand it over to Robert to wrap us up.
Thank you, Ashley. Thank you, everyone, for being here today. We have included Ashley's contact information so that you can contact her with any further questions. Ashley, thank you for all the work you put into today's webinar, all the valuable information that you shared with us today. Everyone, please note a couple of business items before we conclude. The first is regarding the evaluation. I am going to put a link in the chat for everyone to access the evaluation. Additionally, when I end today's webinar, your web browser will populate a message that says the host or presenter would like WebEx meetings to open a website on your computer. Click continue to be automatically redirected to the evaluation. To complete the evaluation, you must sign into your FATA account. If you do not have an account, you can register for one at no cost. You can do so by clicking haven't registered yet underneath the sign in boxes. You must use the same email address you used when you registered for today's webinar when you set up your profile in FATA system. So if you registered for your webinar today with a work email address, please use that same email address when you set up your profile. This is the only way for us to be able to connect your attendance and your profile. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the Professional Information section of your profile. You will get a third opportunity to complete the evaluation through a follow-up email later today. As a reminder, the evaluation deadline is Monday, June 3rd, 2024. For assistance with account login, account registration, or evaluation completion, fill out a Contact Us form on our website. Please note that we do not email statements of credit. Instead, after we verify attendance and evaluation completion, a statement of credit will be posted to the professional development section of your profile within 30 business days. You must have attended the entire webinar and completed the evaluation to receive a statement of completion and CEUs. We are not permitted to provide partial credit or a partial statement of completion. As a reminder, the recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you everyone for participating in today's webinar. Thank you again, Ashley, for your time and the information. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone, and please hold for the evaluation.